Is it being broken down, or is it due to loss of blood cells, i.e. bleeding? Pharmacy lens on things, basically we look at helping with the production. So when we start looking at pharmacotherapy for anemias, define anemia right, reduce oxygen carrying capacity of blood, and usually you're going to see that how in the lab, low hemoglobin and hematocrit. And the normal numbers for men versus women there, don't need to know it for the test, but as you move on with your studies, you will. Basically, to make red blood cells, there's 3 main nutrients we're looking at that the body needs to do so. Iron, vitamin B12, and folic acid. And that's one of those are the 3 that we're going to discuss briefly here. And you also have to have some growth factors present. Basically, if the bone marrow is deficient in any of these 3, the iron, the B12, the folate, then you're not going to be making red blood cells. And you look at treatment for anemias is replacing the deficiency of whatever is causing it. Iron deficiency, most common worldwide. It's microcytic, means it causes small red blood cells. Usually iron deficiency is blood loss. It can be a GI bleed, menstrual bleed, malabsorption can cause microcytic iron deficiency. Next, vitamin B12 deficiency. Opposite, it causes big blood cells, macrocytic, or a megablastic anemia. It's unique because with vitamin B12 deficiency only, you're going to get neurological symptoms. So that's a key takeaway for that megablastic anemia. With macrocytic cells, it's B12, but not folate or iron. You can get neurological changes. Paresthesias, ataxia. And then finally, folate is B9, and that deficiency will also cause macrocytic anemia, but I just told you the key differentiation between that and the B12 deficiency. No neurological symptoms. Folate deficiency, B9 deficiency is very common. Alcohol use disorder, poor diet, pregnancy, and then some medications, methotrexate being a big one that can cause it. Just know that the presence or absence of a neurological symptom in a megablastic, at least for the limited view we're looking at anemias with today, that our 3 causes, that if you get neuro, it's vitamin B12 and not folate. Replacing the folate may help the anemia, like the cells may start to be large again, but you're not reversing the actual cause of the anemia, and you have to get the B12, or else the neuro symptoms are going to progress and progress and progress. For iron deficiency, we give iron, right? And then there's some common ones. It could be oral or IV. The percentage there is of elemental iron, not of milligrams of the pill, but we need to usually give about 100 to 200 milligrams for an iron deficiency anemia. 100 to 200 milligrams of the elemental iron, not milligrams of the tablet, but the iron content. After you correct the anemia, you need to stay on the iron supplement for a good 3 to 6 months after. So once the hemoglobin normalizes from those numbers we discussed in the last couple of slides, then you still need to be on the iron for another 3 to 6 months after. You can increase iron absorption with vitamin C, but there can be some tolerance. Oral iron is the best. That's the drug of choice. Biggest barrier there is going to be adherence, like we talked about with some of our other medications. What you have to tell your patients is with iron and oil supplements, you're going to get dark black stools. And constipation is very common. 2 key things you should know about oral iron supplements, those adverse effects. Dark black stools, normal, and constipation. Big problem with adherence here is consistency, because you only absorb about 25% of the iron that you take in. So those patients have to take their medication as directed constantly to get the iron loss replaced. You don't want to give iron with any antacids or PPIs that decreases the absorption. IV is basically if you can't take oral iron. A lot of times you'll see IVs being given inflammatory bowel disease, small bowel resection, gastric bypass, chronic kidney disease. And then if the patient has really heavy bleeding, sometimes we'll have to go IV iron to keep up with the blood loss, right? Don't really need to know about the different IV formulations of iron. Just know that it can be PO or IV, and then the adverse effects that I mentioned. With the IV, kind of the same thing. GI upset, you can get a hypersensitivity reaction with some of the iron products given IV, and there is a risk of anaphylaxis, but normally the risks don't outweigh the benefits of getting iron on board, unless they've had a past anaphylaxis from an IV iron preparation. There is an antidote. Remember I told you, if we're giving something and you do too good of a good thing, we need an antidote for some of these products. And the antidote for iron is deferoxamine. It's right there on your slide. All right, moving to B12. B12, essential for DNA synthesis, fatty acid metabolism, and conversion of homocysteine to cysteine. You don't need to know that, but you do need to know that for B12, it requires an intrinsic factor, and that's from the stomach, so that it can be absorbed in the GI tract, specifically at the distal ileum. It's also transported as a complex with transcobalamin 2. Not that important, just be aware it does have a complex that it must, to be able for your body to utilize it, has to be transported, co-transported with transcobalamin 2. The B12 is stored in your liver for years, and the deficiency gives you, like I said, megablastic or macrocytic anemia and neurological dysfunctions. So basically, any issue affecting your stomach or your terminal ileum, where the B12 is absorbed, like a gastric bypass, pernicious anemia, which you get in HEMOC, or like Crohn's disease or inflammatory bowel disease, any of those can lead to that B12 deficiency. You can also get it from poor intake of B12, so can be from a vegan diet. You'll see that sometimes. It's in one of your check on learning questions, I think. Intrinsic factor deficiency, I told you about needing the intrinsic factor to be absorbed from the stomach to be absorbed in the terminal ileum. So if you have a deficiency in that, you'll learn more about that mechanism in HEMOC, but you can get a pernicious anemia for it, from it. Pernicious anemia is not on your test. Like I said, a post-gastric surgery, whether that be a gastrectomy or a bypass, sometimes you'll see the B12 deficiency come into play. You do need to know how we treat it. IM is hydroxycobalamin. That's the preferred agent because it's longer acting. So it's an IM injection into the muscle. And then cyanocobalamin is used either IM or PO. If you have that deficiency in intrinsic factor, then you're going to be on these for your entire life, basically to absorb B12, to be able to absorb B12. B12 replacement needs to start immediately if you have a megablastic anemia with neurological signs and symptoms. So get it on board quickly because those neurological changes from a deficit in vitamin B12 can be permanent neurological changes. So megablastic anemia, neurological paresthesia, any other ataxia, any other neurological signs and symptoms, get going with the B12 injections. So some side effects sound pretty harsh, right? You can get pulmonary edema, thrombolysis, sensation of swelling, but overall B12 injections are pretty safe. overall. And don't give folate when there's neurological symptoms. Like I said, if you don't get the B12 on board, you're possibly going to be having a patient with permanent neurological changes. So folic acid, vitamin B9, it's for DNA synthesis as well, absorbed in the upper small intestine, and its active form is dihydrofolate reductase. You don't need to know that, just be aware it is broken down to an active form. Folate deficiency can be from your diet, alcohol, as I mentioned, malabsorption. Pregnancy can, just because you have increased needs for folate. It's often in the vitamin supplements we're going to get to our pregnant patients because of the increased need for the folate for the embryo. Hemolytic anemias sometimes can lead to a folate or folic acid deficiency, vitamin B9. We just give oral treatment to reverse it. Usually 1 milligram orally daily until it's reversed. You don't need to know dosages. There are medications, same one that can interfere, such as methotrexate, TMP, or trimethoprim. And there's some medications that can be used to bypass a blockage from the antibiotics we just mentioned, but that is outside the scope for this class. Basically, folate deficiency, megablastic, not having any neurological symptoms, and it can be easily replaced with an oral pill. Pretty much hit it. Special pops. Typical populations for folate deficiency is pregnancy and alcohol. Some of the anti-epileptic drugs can cause it. Can cause an interference with absorption of the folate. And I mentioned before, if you give folate, but you have an underlying B12 deficiency, then your anemia can look better, under scope. It can be reversing, and the megablastic appearing anemia and the loss of the dropping of the hemoglobin. But if you don't get the B12 on board, then neurological symptoms could come. I'm going to briefly talk about EPO. So erythropoietin is a growth factor. It's from the kidneys, renal derived. It's a glycoprotein, and basically it's stimulating your red cell production. It binds to receptors and the red blood cell precursors and prevents them from basically being broken down, that apoptosis that we've talked about before. That way they can differentiate into mature red blood cells. Like I said, made by the kidneys, and the levels can actually increase due to hypoxia. And chronic kidney disease can often impede your normal EPO, the erythropoietin growth factors. And what do? We try to stimulate that. And so there's a couple of ways that we can. I'm going to show them to you just for your essay, but you're going to go deep diving in some of the treatments to increase EPO in HEMOC. So we won't steal their thunder. One key point to remember, though, that if you want to increase EPO stimulation, there's some medicines we're going to talk about that you can use to stimulate it. Then your iron stores have to be normal. You can't start treating or trying to increase EPO without proper iron on board, or it won't work. So here's the agents. You normally see the one on the left a little more, but take-home point here is these are ESAs, so that's erythropoietin stimulating agents. They increase that process, like I mentioned, of the proliferation of the erythroid to red blood cells. So the precursors from the bone marrow into making those into red blood cells. And once again, you have to have adequate iron stores for the EPA to work, or the ESA, whichever one you choose on the top there. So often you'll see our chronic kidney disease patients need an ESA, or our chemotherapy patients that are getting anemia from either chemo or radiation. Okay, last slide just for your essay. Just like we can increase the proliferation of red blood cells with the erythropoietin stimulating agents, we can also do that for white blood cells. And you will get more than you need of this next semester. But basically, this growth factor is a glycoprotein that's going to cause those precursor cells to become white blood cells. And we need these a lot of times when our normal white blood cell count is being affected by usually a type of bone marrow cancer, leukemia, or if we're undergoing chemotherapy, our patients undergoing chemotherapy. These are for your essay. They will not be testable. Okay, so now we're at the memory jog. I'm going to go back instead of going through the hematology ones first. I'm just going to go back in reverse order from hypertension. A couple of slides on each subject. We'll go through them quickly. Just basically kind of guide you where you need to be focused your efforts over the next 5 days or so, 6 days, until your test on Monday. So hopefully you've looked at these. Take a second here to just bring those up, and then we'll just basically go through those quickly. If I can find them. All right, so we're going back to hypertension. So backbone, right? When we think about hypertension, and remember as we're talking through this that some of these medications we talked about in hypertension, then we talked about them in diuretics, then we talked about them in heart failure or angina. So there's some things that are mentioned, there's some key points that transfer into other processes that I just mentioned, or other morbidity or comorbidities, but then there are some that don't, i.e., they could be helpful in one situation and not so helpful in heart failure, and vice versa. But for hypertension specifically, this is how I would recommend you approaching this, is I would learn it by disease process. And hypertension, we almost hit a lot of things as we moved into angina and heart failure and the coronary syndromes, so and diuretics, because we talked about diuretics extensively, and the backbone, the thiazides and thiazide-like in hypertension, but then we hit some other classifications of drugs that are diuretics, but different type of diuretics that we use more in heart failure and so on. So keep in mind when you're studying these memory jogs that when it's the hypertension one, it's focusing on that, which I told you on your test, we're not going to have you diagnosing, so we're probably going to, well, I know you're going to be asked, a patient has a blood pressure of this, and treatment, right? So you look at backbones, we're going to give you stage 1, stage 2, so you have to know how many medications are on board for stage 1 versus 2, which is easy. Stage 1 is 1 from this backbone class. Stage 2 is 2 from this backbone class that you see in front of you right now, the thiazides, the ACE inhibitors, and the calcium channel blockers. So for hypertension, these are your first line medications unless there's a contraindication to one of them. And the key point is, if it's stage 1, use any of them. But if you're going to choose one, you probably want to use the one that has the most mortality and morbidity decrease associated with it, right? So if it decreases morbidity, mortality, hospitalizations, that's the one you should probably choose first. But as far as a stage 1 hypertensive patient, choose one from the class. Stage 2, choose 2. And when, a lot of times when you see the questions, if they're stage 2 and they're on one medication, and what do we do next? That's what we're going to think about on a lot of these scenarios. Just like if you looked at the check on learning, we're going to think about, well, okay, you got this on board, but they're stage 2, what next? We'll always think about your backbone, your first line medications. That's what's next, right? And then think about what's going on with your patient. And you have to know, I know we deep dove into like the pathophys, mechanisms of actions, but you have to know those mechanisms of action, because if you don't know, hey, okay, my next my next choice would be this. However, the patient has bradycardia. Well, you don't want to give them something that is going to decrease their heart rate, right? Like the non-DHP calcium channel blockers, or a beta blocker that's cardio-specific. Or in some instances, we may want to give something that's going to decrease the heart rate. So just keep the signs and symptoms in mind. We're going to give you the diagnosis and choose the first line. So key notes about the hydrochlorothiazide or chlorothalidone, which are backbone diuretics, right, for hypertension. They are potassium and sodium wasting, right? So what's that going to do to your blood work, right? What are you causing? You need to think about, if I'm losing those, what's happening in my system? Well, if we have a whole class called potassium sparing, then probably most of the other diuretics are going to cause potassium loss. So if you think about the mechanisms, you should be able to kind of deduct what's going on, whether it be in the kidneys or in the blood. So they can increase blood glucose, the thiazides and the thiazide-like, and it can cause uricemia. It's not the only diuretic, right? Remember, loops can cause uricemia too, so gout. We did talk about the creatinine clearance, or creatinine clearance, rather, being limited, right? If it's below 30, then your thiazides and thiazide-like stop working, except for one. That's an important thing to know, is that there is a thiazide or thiazide-like, and I think it's actually in the next MEMORY JOG slide that actually works below that 30. But the loops all do. And sulfa allergies comes into play with both of the loops and the thiazides, and we'll hit that. And so, as I mentioned, there's some things like the uricemia, so increased risk of gout, that when we talk about loops, we didn't really talk about it in hypertension, but they have the same sulfa allergy and causing increased uric acid, so it can lead to gout. And then we talk about our ACEs. So opposite of the thiazides, right? What does it do with our potassium? It increases it. And remember, we kind of had a cutoff for adding anything that's going to increase our potassium in our blood. So if we're getting hyperkalemia, then we don't want to add on a bunch of drugs that are going to raise it. And we said that kind of ceiling was 5, right? The slide saying 5.5, but if it's anything over 5, you want to avoid, which comes to mind big time when we talk about heart failure. We get to that one because in heart failure, remember we got our multiple classes, A, B, D times 3, and some of those medicines specifically increase potassium in our blood, hyperkalemia. So you want to know that cutoff. This one says 5.5 for the ACEs, but we said 5 as a rule when we're combining things in heart failure. So keep that in mind. Remember, the monitoring on the ACEs are a little faster. We said for the diuretics, we're looking at a month or so, but 2 to 4 weeks on the ACEs. And then what's unique about the ACEs and ARBs, which are going to be across the class, across the morbidities that we're going to talk about, is that you're going to use an ACE or an ARB in almost all cases where you have albuminuria, protein in the urine, or diabetes. So those special cases, those compelling factors, you usually want to get an ACE on board. So keep that in mind when you're choosing Your first line, if your patient has albuminuria, start thinking ACE or ARB. Then we mentioned when you can't use them, you don't want to raise the K above 5. Pregnancy, absolute contraindication. Renal stenosis, absolute contraindication. And we're using them just ACE and ARB, we're saying that as a class. Either or, they do the same things, right? Just at different, at different receptor sites in the RAS system. Remember on the ACEs, they're the ending of the words, right? Prill and Pratt, there's one Pratt, but most of them are Prill. And then the ARBs are the sartans. So that's the key to picking them out of the lineup. But be very careful with that because there's a lot of other medications that kind of look like a Prill, but it's not quite, right? It might not have the R there. Or the sartans. Just be very cognizant of if you're just picking things based on, and you can, right? You can pick based on the ending of the word, the suffix, but just make sure that you know that it's P-R-I-L and P-R-A-T and S-A-R-T-A-N because there's a lot of medications that look similar. So it's just a testing caveat. Make sure you know if you're going to, and I encourage you to remember how to pick them out of the lineup, but make sure you know exactly what it is, not partially. And then the third backbone medication, calcium channel blockers, and then you have your two classes, your DHPs and then PHARM. And then you have your non-DHPs, which are more selective for what? The heart or the lungs? Heart. Got it. Non-DHPs, heart. And it slows it down. So would you want to give a beta blocker and a non-DHP to a patient in heart failure with a pulse rate of 55? No. And we'll talk more about that when we get into heart failure. But one thing that's been on the slides, I don't think I hit it very hard, but definitely be aware of the nifedipine side effect of gingival enlargement. That's like your gingiva of your mouth. So gum swelling, and it's kind of not well understood, but basically because of the calcium influx, something goes on in your soft tissues of your mouth and your gums, and nifedipine is the culprit, and you need to know that. We talked about non-DHPs decreasing the heart rate, and then they can cause complication, especially the verapamil. And it says right there, no beta blocker with a non-DHP. Both drugs doing the same thing is too much of a good thing. And then we talked about heart failure with CCBs. Don't use them. Okay, moving on. And then the thing at the bottom, thing at the bottom, remember we said the old literature kind of was, well, with an African American, self-identified African American, we might want to go to calcium channel blocker over an ACE or an ARB, and I told you, don't worry about that. Choose from the backbone here, except for the specific indication we talked about in heart failure, which we'll get to that. But for hypertension, the backbones are the backbones. Pregnancy, there's 3 drugs, right? 3. That means I would know those. And what class they come from, and we'll get into, I think, this next memory jog slide, but all of the classes of drugs, make sure you know the MOA, right? We talked about what happens, right? Are they potassium sparing or potassium loss? But know where they're acting at, right? Where are the thiazide-like acting in the tubule, and what's it causing? Same thing for all the classes we're talking about. MOAs are a big thing. Methodopa is an alpha-2 agonist. I changed this on your slides, and I don't know if and I had to change it here in class, that it was mislabeled at the top as an alpha-1, but it's an alpha-2, right? We didn't talk much about another alpha-2 because you're all sitting here, which means you passed PHARM 1 with clonidine. So clonidine we didn't mention much because you passed the test last time.
The hypertension memory jog slides are not there.
They aren't moving? Oh. Let's see. Let's see why. Is it blank now? Oh, still got that up? Let's see if I can change it. not moving. Do the same thing. Let me change it here. Sorry about that. Was it up before, or has that been up the whole time? Okay, that's okay. You've had the slides for a while. Is it still up there now? All right, back in business. Didn't come up? All right, let me change the screen here. Okay. Now we're in business, right? Okay, so we'll just briefly, everything I said about thiazides, ACEs, and calcium channel blockers are there on the slide. And we're at this slide. I mentioned for pregnancy, really think about those three medications, know their classes, know their mechanism of action. I mentioned that the alpha-2 agonist, methyl-dopa, is safe in pregnancy. Now, when we say safe in pregnancy, do you keep them on their ARB and their ACE and add methyl-dopa? Or do you take them off their ACE and their ARB and put them on methyl-dopa? Yeah, the ACEs and the ARBs are contraindicated in pregnancy. So if a patient is on something and they become pregnant, you discontinue. You don't just add to a contraindicated drug. You take them off and you change it. Beta blockers, we have talked about some of the side effects. Main one is, you can get too good of a good thing and get bradycardic. There are some high notes about taking someone off of it, withdrawal, reflex tachycardia. Sexual dysfunction can be a side effect that patients can complain about. And then caution in asthma and diabetes with the beta blockers, right? Because they can be agonists against those beta agonists that folks take for their asthma. So better for the cardioselective ones, which means you need to know on the beta blockers how they're differentiated in the class, right? You've got the beta 1 selected, you got the mixed, and then you've got ISAs, or and then you also have the non-selected. So for the selective ones, it says they're A to M and non-selective N to Z. That's like alphabetized. Mostly fits into that. And then the mix, carbidolol and labetalol. And then the sympathetic activity ones are good for bradycardia. And the mnemonic there is ACE pin. So basically, that's not the suffix, that's the prefix on those three. If you go back to your list of drugs for the beta blockers, you'll see them listed there, the ISA ones. But just know those are better for bradycardia. CHF, we have some special ones, right, that we can use, the metoprolol succinate and the carbidolol. So there's one more, bisoprolol. But pay attention to the second word for the metoprolol. There's a succinate, there's another one. Well, the other one isn't good in CHF, only the succinate. So make sure that you're aware of that. Don't just jump on metoprolol if it says we're using it for CHF, because there's only 3 beta blockers you can use in CHF, CBM, right? But know that metoprolol, that M, has the second word is succinate. Migraine prophylaxis is propanol in pregnancy. We already mentioned earlier on the slide is for labetalol. You can use it. The vasodilators, hydralazine, you're never gonna use it alone, it's always an add-on. We talk about that more in CHF, and actually more in angina. Clinical pearls, hypertension equals diuretic, right? Managing that fluid overload. I mentioned, look at your MOAs, where are they acting? Know where the thiazides and thiazide-likes are acting in the tubule and what they're doing. And then adverse drug reactions for any of the classes, that's going to be a big one. These are just more clinical, not so much testable, but take in the morning to avoid nocturia, i.e. if the drug's going to make you have to go to the restroom more, it's better to take it in the morning so you don't have to get out of bed numerous times at night to go to the restroom. Stage 1 for hypertension, 1 drug from the backbone list. Stage 2, 2 drugs. Any from the list. Don't start adding non-backbone adjunctive things that are useful until you've ran out of options on the backbone list. Start low, go slow, and follow up 1 month after initiating. And we said for ACEs though, how soon? 2 to 4 weeks. Yeah. And I believe that's the last one for hypertension. I'm not going to go through the check on learning questions because as you go through them, they're hung. It asks the question, gives you your 5 options, just like you're going to see. I would look at these. And know, just like I went through the effort of pointing out on the next slide, on the answer slide, why that's correct and why it's incorrect. So you might not see the exact check on learning questions, but you may. But certainly I would know the distractors and what is said in the explanations of why they're incorrect. Because all those points are important. All right, I'm going to get out of this one and go into diuretics, which is what we did next. There's 4 or 5 check on learning questions in each of the lectures hung in the card. So let's see here. All right, going on, moving into diuretics. So we already talked about thiazide-like. We're thinking first line backbone for what process? Hypertension, right? Backbone for hypertension. And then long-term BP reduction, is that caused by the sodium and potassium loss? It starts it, but actually the long-term benefit from those medications are the decreased peripheral resistance that they cause over long term. Proven mortality benefit. That's why it's first line hypertension. You can give it once a day. It helps our adherence from our patients. Well tolerated and expensive. All good things to know about the thiazide-like. So we talked about the fact that we had a floor basically for functioning of the thiazides. Creatine clearance of what?
30.
Creatine clearance of what? Yeah, below 30, not going to work, except for metalazone, which is the one thiazide-like that works at a lower creatinine clearance and is there at 10 to 20. I would know that. And then the loops all work at a lower creatinine clearance with less kidney function than the thiazides. And we're going to think loops when we're thinking get rid of fluid, right? When we're thinking diuresis, especially when we start to get like heart failure where the fluid builds up, backing up in our lungs and getting edema, then you think more loops. We already talked about the diuretics can cause hypokalemia due to, it causes hypokalemia, but you can also increase digoxin toxicity with hypokalemia. The key point is that they cause hypokalemia. Monitor K. right? Monitor your potassium. We talked ad nauseum about the NSAIDs reducing the effectiveness of the diuretics because it inhibits that prostaglandin synthesis. So the loops and the thiazides, we just talked about the thiazides, but the loops have the same effect of causing hyperuricemia, so increasing gout risk. And then spironolactone, which is what type of diuretic? MRA, right? Cord receptor agonist or antagonist. You can get gynecomastia. So what happens if the patient is on spironolactone and they get gynecomastia, but the spironolactone is helping their heart failure, we just switch them to the eplerenone. Just switch them. Same drug class. There's another group of, there's a whole other class of potassium sparing diuretics we didn't talk that much about, but you need to make sure you look at that slide. We talk more about the MRAs because they're in our AG or our ABD times 3 for heart failure, but don't forget about the other class, which do what? The other group of medications, the subclass of potassium sparing. Does anybody remember? You got the MRAs, which are the two there we just talked about with gynecomastia, and there's a whole other group. Sodium blockers. Know those. Know where they act, and don't forget about them. Is what I'm saying. Know, be able to put them out of the lineup and know what they do and where they do it. And actually, they're there for you. Amiloride and tramturine are in the next bullet. But they all risk hyperkalemia. If they're in the group of potassium-sparing medications, then you're keeping your K. Potassium can go up. Goes up too high, then you're going to start getting the usually the arrhythmias, some of which can be fatal. And we talked about ACEs and ARBs increase that K. So if you're if you got an ACE or an ARB on board, whether that be in heart failure or hypertension, and then you're adding a medication that's a potassium sparing, which we do for heart failure, it's in our ABD times 3, right? An ACE, and then MRAs, proven, decrease in mortality, got to monitor the K. Am I going to start someone at 5, if their potassium's at 5, and they have heart failure, and they're already on an ACE, am I going to start them on the MRA? No, because the risk outweighs the benefit of adding on that backbone treatment for CHF. We'll go to something else that does not increase potassium. I mentioned in the thiazides that hypoglycemia is linked to decreasing K because they're not potassium sparing, or else we wouldn't have a whole subclass of potassium sparing drugs. So, but the reason that folks get hypoglycemia when they're on the thiazides is because that potassium is dropping out, and we need that potassium to help transport the sugar. Basically, diuretics all act by inhibiting sodium reabsorption in specific locations on the nephron. Know where they act and what they do there. Loop diuretics, most potent. Lots of fluid on board, got to get rid of it. You got rails in your lungs, you got pitting edema, you need a loop. Is that loop going to decrease morbidity and mortality in our CHF patient that we put on the furosemide to get the fluid off of their lungs or out of the periphery? No, it is not. So the diuretics in heart failure, yeah, it's ABD times 3. Only the MRAs are going to decrease mortality and morbidity. The other medications are symptom control only. They help with the symptoms. So you throw a loop on, super potent diuretic, get rid of all that fluid, but you're doing nothing to prolong morbidity and mortality like the other. That's why they're not A and B in that equation, or the first diuretic. We're going to always use thiazides first line for hypertension, and they reduce calcium excretion. So if we're not losing calcium through our kidneys anymore, they're reducing the amount of calcium that's going out of our kidneys. Thiazides actually help with folks that have kidney stones. because that calcium is no longer being stored in it or being brought into the kidney in higher rates. It's actually going back out into the blood. So because they reduce excretion of calcium from your body, they can actually help with kidney stone thiazides. CAIs, we said they're not really used that much for just diuretics. We talked about a couple of basically niche uses for them, but they're the ones that cause metabolic acidosis. With metabolic acidosis, they're also going to increase the pH of your urine. So they do the opposite of what we just talked about that the thiazides do with calcium. They lead to kidney stones. The main thing I need you to know about the CIAs and the carbonic anhydrase inhibitors is because of their action to cause metabolic acidosis. Remember we talked about glaucoma, altitude sickness, and if you're doing wilderness medicine or at base camp in Nepal, you may be using this drug, but some of your patients may be on it for glaucoma. But just know that because of the metabolic acidosis, it causes a pH to increase in your urine, so you're going to, it's like tenfold the risk of kidney stones with CIAs. That's important. Osmotic diuretic, mannitol, that's usually only in head injuries. We talked about it, IV. I said it over and over and over again, what we need to monitor for diuretics. No one should miss a question about what we monitor in diuretics, right? Really ACEs, ARBs either, but obviously we need to know, though we're monitoring potassium and sodium, calcium, some diuretics are going to be potassium elevating in our system, and some are going to be potassium lowering, i.e. We have the class of potassium sparing, meaning we want to keep potassium in our system, versus all the other diuretics get rid of our potassium. So the kidney function test we talked about, volume status, blood pressure obviously has to be monitored. Across the class of diuretics, hypovolemia, electrolytes, and orthostatic hypotension from decreased fluid in our system. And that was it for diuretics. Why don't we take 10? We'll come back and finish up the last 3. Another 20, 30 minutes, and then we'll be out of here.
Oh.
Did we do an engine or horse failure first? So there's still the interaction. It's like 10 ways high. It's like a 10-way calculation. Yeah, the last two. So if it's product rhythm, you can yell at her. It's like a 10. Yeah, it's like 15%. Our average is like the last 2 rows, 3.5.
What's that?
I'll break that because I had it written down. Because I look at the average rate.
$600 difference in taxes took last year's this year.
I told you it was way off. I know it's way off.
No, because last year was different. Fine, I mean, it's like,
way.
if you don't get a tax return, it's not a bad thing.
I'm overselling.
I'm so excited and dying.
Little, I don't like the kids. You start getting like, money somewhere else at top, they start getting just like basic, like, you got a job, whatever they take, like your monthly pay, they don't own it. They take 2 months to get it. They don't see it.
She has a bunch of some new books. She was like, I came in and she saw those. So I think maybe she was at the gym. She actively has.
Well, I just barely. I was able to bounce back from that I did last semester. Exhausted already because like just wanted to way more now. And I can't do like 2 or 3 at a time. I gotta do like 4 or 5 at a time.
She's really. She has all this stuff.
Yeah, like it's the travel one, like where I'm like 22, so like my last travel one was in 23. So that's where it's 25.
I always wanted to have like give it a year of
Or just find out a disc you really like and stick with it.
For like virtual side effects.
That's 3 or 4 days to have like
For more than anything, books, like those kind of books, that's really what you decorating off farm.
the amount that were like What sound is it?
You happy here?
What's the good?
I saw where.
You got
Put it in water bottle. You put it right there. Put it right there in front of it, because it's always came back in the game.
I looked it up and I was like, it was graduation present. Yeah. And like the engagement thing that I said. Graduation for sure.
I don't want to be that person.
Yeah. So careful for the engagement. Not enough.
I was hoping you don't take an hour so we can.
Yeah, nobody's exactly. It's all like, I guess like back and forth. I don't know. So it looks like Friday it didn't rain. Saturday and Sunday it's I don't know what that rain that was rain overnight. Because it says here Craig, yeah, I've done 3, so the rain happens today and dries up. You won't be out of that. That's when that rain happens. Yeah. But as long as that rain comes out, then you won't have one
All right, let's go ahead and get started back up. We have 3 more to get through here.
Hey, sit down. Good.
So moving on into heart failure. Like a lot of the drugs, like, you know, the normal cast that we've been talking about, looking back at hypertension and then looking at the diuretics just as a whole. But now we're talking about, just like hypertension, now we're talking about a specific disease process, which is going to highlight or asterisk differences between some of the classes of medications which are backbone in hypertension, not so much in heart failure, actually very contraindicated in heart failure, and vice versa. Some things that were background, actors in hypertension and diuretics now move to the forefront in heart failure and become part of our backbone. We talked a lot about sympathetic nervous system and the ROS system and aldosterone and how that neurohormonal activation drives heart failure progression. And obviously, since aldosterone is a big player for both hypertension and maybe more so in heart failure, then the medications that we kind of focus in on is remember the GDMT, like the guideline-directed medical therapy that we call the ABD times 3 for short, to help you remember them. So in that ABD3, then you're going to see actors that are impeding the aldosterone because of the remodeling and the fibrosis on the heart that's caused by excess work of the heart, reactivating the RAS, re-kicking aldosterone in, which causes that heart to thicken. And remember the picture. So basically trying to get after how do we prevent that from happening, which is preventing morbidity and mortality or natural progression of the disease process. But by the way, there's some signs and symptoms that need to be treated as well, because a lot of times we will have that congestion and will be wet heart failure that we need to get rid of some of that fluid with diuretics. So as I mentioned, HFrEF, that's how you're going to see it on your test. HFrEF, everybody hopefully knows that's heart failure with reduced ejection fraction. If you remember, we defined it, but myself and Major Hart wrote it as, we may say, remember the stages at the end of this slide deck? We talked about the New York Heart Association stages or classes, class A, B, C. You'll see that because you will see that once you get to the pants. However, you're not going to have to determine what stage heart failure they're in based on that. Just want you to get used to seeing that. But if it says HFrEF, then and also the ejection fraction sometimes, and some of the questions are in the parentheses as well. But it's HFrEF that you're worried about at this stage in your training. It's HFrEF, you know that it's below what percentage of ejection fraction?
40.
Right. So if it says HFrEF, and then if you go on further down the stem, it's class C, stage whatever, ejection fraction, whatever percentage. That's there to further define, but the diagnosis is HFrEF. That's all you would need to know about that question, unless we say it's HFrEF and the patient is having whatever. But the classification or the stratification of the HFrEF, that's not going to change your treatment, right? It's not going to change what we're asking you as a student in this semester to do. Just know that it's HFrEF, and then you want to just move past the parentheses or the hyphens or the commas of what's after it. By all means, you can do so, but you're not going to get further clues for what we're asking and what knowledge we're trying to get you to portray in that test question by knowing stages and classifications. We just need you to know HFrEF. Okay, diuretics relieve congestion. Do not improve mortality, except for what class in heart failure? MRAs. All other diuretics, only symptom relief. And look specifically. So if it doesn't say MRA diuretics, you're looking to see, oh, is it a loop, is it thiazide, and does that decrease mortality in my heart failure patient? The answer is no, only MRAs do. We introduced a couple of new classes, right, in HFrEF, in our guideline-directed medical therapy. We added to the ACE and the ARB, which is backbone in hypertension, we added this new medication, ARNI, right? And we're saying that basically, first line, our A can be an ACE, an ARB, or the ARNI that we discussed. Change this over to. Okay. So, using our guideline-directed medical therapy, or ABD times 3, it's an ACE, an ARB, or an ARI. You don't combine any of the A's, because they're all doing the same thing, just different mechanisms. And then your B is a beta blocker. We said on the last discussion, memory jog, there's only how many beta blockers that we're going to use in heart failure? 3. Remember what they were? CBS. And that the M, the metoprolol, is the specific one, since there's a couple. Okay? And then the MRA, which we said that's spironolactone, right? Because we know what it does. It's an antagonist of aldosterone. And we just talked about remodeling, and a lot of us do aldosterone. So if we get an aldosterone antagonist on board, that helps. But if we get gynecomastia from it, we switch off spironolactone and move to Clairol, the other MRA. Okay, then the second new medication we introduced are these SGLT2 inhibitors, right? And remember that with that medication, that's our mnemonic for the D, right? And that's because that's the common name of the most common SGLT2. Remember, anybody remember what it is? DAPA. Right, so there's only a couple, the dapagliflozin and the empagliflozin. But don't get thrown off by your D and say, oh, well, SGL2 is not a D. Right, it's based on the fact that the most common SGLT2 is the dapagliflozin, which is the other D. So the first D was a diuretic, which was an MRA. That's backbone. Then your second D is your SGLT2 inhibitors, and that's the dapagliflozin. And then you add on the other D, which is the diuretic that is optional. That's for fluid control. Everybody's with me on that? Guideline-directed medical therapy, ABD times 3, ACE ARB or ARNI. Anybody remember the ARNI?
Trust.
Right, it's a combination, right? It's a neprilysin inhibitor with an ARB, right? That's why you can't say, well, I'm going to take 2 from, I'm going to do an ARNI, I'm going to do an ARB or an ACE. Your potassium just became a big problem. So one of the ones, ARNI, which is, like you said, the ARB mixture with the neprilysin inhibitor, and then your beta blocker, one of the 3, with the succinate on the metoprolol, and then your MRA, which is your spironolactone, which is a diuretic. That's your first D, specific class of diuretic, potassium sparing, and then your SGLT2 inhibitor, which is the dapagliflozin or the empagliflozin. If you see a patient, HFrEF, and the question is, what do we do next? Write on your scratch piece of paper, A, B, D times 3. Okay, well, what are they on? check, William, check, check. Okay, which of the four are they not on? Which of these four is missing? And then that's all you gotta do is fill in the puzzle, right? However, look and make sure that the patient doesn't have any complications, right? If we already talked about if our goal of treatment with a beta blocker or a non-DHP calcium channel blocker is a heart rate around what, 55, we said? So if your patient's at 50-ish or 55 and below, would I go ahead and add on that beta blocker? No. Right? No. What else can you use? So if there's a contraindication to one of the four, what else can you use out of that class that they may not be on? But we don't add on things because they're in the four that are contraindicated by their signs and symptoms. So just think it through, think of the four. But if there is a glaring problem, think about the mechanism of action of what you may be adding on and make sure you don't make the problem worse. Okay, let's see here. We talked about the diuretics. We talked about our new class, the dapagliflozin. And those do reduce mortality and hospitalizations. That's why they're in our GDMT. So here is our bullet that I mentioned last time when I told you hypertension, just use one of your backbones. However, the research is still showing that this combination, hydralazine with the isosorbide dinitrate, which it says nitrate at the end, so nitrate always tells us that the mechanism of action is what? Vasodilation, right? So you see nitrate is dilating. That's what it's doing through that nitric acid production, but you need to know that nitrate's dilating. This class of medications is still recommended for HFrEF African American patients. You can ignore the NHA3, but it says HFrEF at the end, right? So for self-identified African American patients, this classification, this medication, the combination of the hydralazine and the isosorbide dinitrate still improves, has been shown to improve outcomes. However, would you put your patient on Endure, that medication, the brand name, this nitrate and hydralazine combination before you finished out your backbone 4? No. Backbone is backbone. Don't do fancy extra that's been shown to help until you do the 4 or the 3, according to which process you're talking about, hypertension or CHF. Do your backbones first, if possible. Extras are nice, but don't jump on a demographic of a patient that has HFrEF and say, oh, well, they would benefit from, Vital or from a nitrate. Well, they're not in our GDMT, right? Nitrates are not there. So look at getting the 4 basics on board first before you start jumping onto nice to haves. You want to go with the have to haves. Just a warning. Normally with this, you're going to see with HFrEF a lot of board questioning, panry is what else? What else can you do? And that's when you take out your little scratch paper if you have to, or you think it through and go, what in my GDMT or what in my ABD3 or D4 am I not hitting? Myself there. Know the inotropes, right? There's only a few there, but there's specifically for acute decompressed heart failure. We already talked about not using the non-DHPs, CCPs, which is only 2, not using them in these patients because we don't want to decrease that heart rate and decrease the inotropic effect. And we talked about the NSAIDs. be able to pick those non-DHPs out of a lineup, right? Which one of these would do more harm? If the patient's already bradycardia, you don't want to put them on verapamil or Valtazine. And then be able to pick out the beta blockers that are cardio-specific, the three that we mentioned that we can use in heart failure. Excuse me, they're not all cardio-specific, but you need to know which one is and which one isn't. Remember when I said that the beta blocker overall slide that says there's classes? You got the ISAs, you got the beta selected, you got the non-selected, you got the mixed. You need to know what falls into which class. Specifically, if we're saying that a medication is proven as a backbone for a condition, you need to know specifically what type of medication. I.e., if it's a beta blocker, and we know there's only 3, I would know what specific type of beta blocker, the C, the B, and the M, those 3 beta blockers we can use in heart failure. I would know specifically if they were mixed, if they were cardioselective, or what, because hint, they're not all 3 the same type of beta blocker. They all 3 are good in heart failure, but those 3 are not the same category of beta blockers. So I would know those classes since they are so important to morbidity and mortality in heart failure. And just remember the ARNI is a combination that's first line with an ARB, and it's sacubitril, but it's a neprilysin inhibitor. That's the NI. And you'll see that as you go through your study. Okay, moving on to the next one, which is angina. Okay, so chronic stable, we got some acute decompensated and we have chronic stable, right? So we need to differentiate between acute decompensated and chronic stable angina. And then we talked about moving on into, once you have an acute coronary syndrome, you've got some non-STEMI and then you've got STEMIs. And there were some specific medications that we are going to treat based on if it's acute, if it's chronic stable, versus when it gets into that acute stage, is it non-STEMI or STEMI? So chronic stable angina, beta blockers, primary first line therapy. So beta blockers have shown up in 2 of our 3 backbones that we discussed now, right? Were they first line in hypertension? No. Okay, beta blocker primary first line therapy, pretty much most of the class, right? They're listed there for you, but they're pretty much most of the class, not differentiating too much other than you don't see you don't see a differentiating with which metoprolol because it doesn't matter in the angina, both metoprolol, succinate. Alternative first line, if you can't tolerate a beta blocker, why would you not be able to tolerate a beta blocker? Bradycardia, right? It slows heart rate and it decreases ionotropy. So if your patient has too low of a heart rate already, well, you can't throw on a beta blocker and make it worse. Well, you can, you should probably make it worse. Alternatives will be a calcium channel blocker. The non-DHPs are going to work for rate control. Remember we talked about that? The non-DHPs, we're going to see them with arrhythmia issues. Preferred is the DHPs because the non-DHPs have more effect on the heart rate and the strength of heart conduction, the ionotropy. So DHPs are preferred. And remember how we can differentiate the DHPs or the pines. Nitrates, first line for acute symptom release. Everybody that's ever had angina is going to get a sublingual, right, that they can take. We talked about you can only take them in a certain amount of time before you got to call the 911. But nitrates are First line for acute, but we did mention a couple of long-term nitrates. Long-term nitrates, right? The patients can decrease the amount of times they got to take the sublingual and decrease the amount of times they're having angina, especially if it's that chronic stable. We could put them on a couple of combination medications that have like a couple of meds in them, including things that end in nitrate. So if you're looking at long-term control, you can add those in. And then you have to have a short-acting for all of your angina patients, on demand for them to use as needed. We talked about a special type of angina, vasospastic or principal. One of your check-on learnings defines that for you. I encourage you to read it. And then that we use normally calcium channel blockers is the preferred agent in that type of specific angina. First line, and you see there which ones. Avoid beta blockers, right? Because it could worsen vasospasm. So that's specifically in the principal or the vasospasm. Whereas in the chronic stable as a whole, beta blockers are the first line. Acute coronary syndromes, things are getting worse. It's not stable. We might have had chronic stable, but now things are worsening, right? It's happening longer. It hurts more. So in the acute coronary syndromes, Mona B. We talked about every patient doesn't get the oxygen unless their O2 sats below 90. There's a question asked in class, which was a good one. What if your patient's O2 sats are really low? Do we still give them morphine because it does have that respiratory depression side effect from the opioid? We're not going to get that deep, but it's a good question. That's going to be patient dependent, right? If you put the morphine on or not, depending on if their airways crumping or if their O2 sats will continue to fall. But in this scenario, in pharmacology, we're just going to say that Mona B is the answer, and the O in Mona B is only if it's below 90%. In real life, and as you get into clinical decision making, and you're running codes in the ER, you may see some variations on if they're putting the morphine or any other opioid or respiratory depressant on board, depending on what's going on with the patient's oxygen saturation and airway. But for PHARM, this semester, just know Mona B for the acute coronary syndrome. And then oxygen's only below 90%. Nitroglycerin, we're going to get it on board. And then aspirin and a beta blocker if there's no contraindication to the beta blocker. Antiplatelet therapy, right? We talked about all these patients are going to be in antiplatelet therapy that are either having a STEMI or they're going to the cath lab. So aspirins are our player, our number one will be aspirin. But we talked about dual antiplatelet therapy. You're going to add something else on, and we hit that a little harder in the next check on learning, the hematologics. But the aspirin with antiplatelets, the dual antiplatelet, in most cases, is going to be that aspirin, the clopidogrel. And we'll talk what class, and only somebody remembers what class is clopidogrel, what drug class. It's got some numbers in it. P2Y12. Yep. So that's preferred. Now for bonus points, what's the other antiplatelet we use if you're high risk and you go into the cath lab? It's got a G in it. Right. You can pick it out of a lineup, right? GDP, 2, 3B, or some version of that. But that's the other antiplatelet that we talked about. We'll hit that more in heme, but that's usually your cath lab patients are going to be on that one. Most patients are going to be aspirin and clopidogrel. Anticoagulation, we're going to hit hard in the next one, but after a STEMI, we know we're going to be on anticoagulants, right? It's not antiplatelets or anticoagulants. It's antiplatelets, which is a dual antiplatelet therapy, and some type of anticoagulation. We get that in your stroke patients, your patients end up getting a valve or getting a stent. And those are the big players, the unfractionated heparin, the low molecular weight heparins, and your DOACs. your direct oral anticoagulant, but that's still in the thunder from the next memory jog. Stable angina, supply demand issue, reduce oxygen demand. We're just talking about the pathophys there. So we're just trying to get the vessels dilated to get oxygen in. So decreasing the afterload and the preload. First line therapy for chronic stable, I mentioned beta blockers and long-acting nitrates are alternatives. And so are calcium channel blockers, but usually not your 90 HPs. Sublingual nitroglycerin for everybody. And we talk about what the nitrates do. Remember, with the patch or IV, that you need a nitrate-free window of 10 to 12 hours in a 24-hour period. That's important to know. We don't want to get tachyphylaxis. Your patient on the nitro patch, that's a huge patient education point, 10 to 12 hours of a nitrate-free time. We talked about the PDE-5, your Niagara, sildenafil, absolute contraindications if they're on nitrate. Absolute. So even if they're on the long-acting nitrates, which are the nitrates that most people are on because they're using the sublingual only in an emergency to decrease angina. But if they're on long-term angina control with the Vidal or the Imdur, any of those that have nitrate as the second ingredient, one of them with hydrolysis, one of them with a different medicine. But they cannot be on those medicines for their heart failure or for angina and then be also on a PDE-5 inhibitor. Sildenafil, tadalafil, vardenafil. And then we talk about emergencies, 3 doses in 15 minutes, call 911. So for angina, the calcium channel blockers, the non-DHPs is negative ionotropes. So they're useful if you can't do the beta blocker. So we're talking angina, not heart failure, right? So non-DHPs are more selective for the cardiac monocytes. So if you can't do the beta blocker, the non-DHPs are useful. And then the DHPs are potent vasodilators, and there's a couple of representatives there. You don't want to use, remember, the short-acting nifedipine, because you get reverse tachycardia from it. So the nifedipine makes your gums get bigger, and also you don't want to use the short-acting nifedipine, the IR, or the instant release, in your angina patients. And we talked about calcium channel blockers for your principal angina. And once again, it's a diagnosis that is specific for a pharmacological treatment. That is something that will be provided. Don't read into questions and think, oh, this sounds like principal or variant angina. If it is, it will say signs and symptoms which indicate principal or variant angina. Just remember, we're going to get it to you if it's important. If you're thinking, oh, I'm not getting the diagnosis, continue reading. It's there. Like you may see a whole bunch of stuff and you'd be confused about what's this patient got, and all of a sudden it says ACG is this and they're pregnant. Oh, okay, that's what I need to know. There are no questions on your test where you're going to have to read through signs and symptoms and make a diagnosis. If it's important, we get it to you. So we talked about ACS, number 5, ranolazine. Persistent symptoms of angina is beneficial. You need to know ranolazine, what it does, mechanism of action, and when you use it. Why is it important? Remember we talked about, there's a slide for angina and it says this class, this class, this class, this class, this class for angina. Go back and look at it. But if there's side effects from something in that class, i.e. a patient has really fast heart rate, really high blood pressure, really low heart rate, really low blood pressure, and we think, what else can we use? Well, for angina, you want to think about ranolazine. Because look at the second part of the sentence. Minimal effect on heart rate, blood pressure. It does have a warning to look for QT prolongation. You might have started seeing that in EKG with cars already. But for us, the main thing that you need to know is that the linolazine class for angina, if you cannot tolerate a beta blocker or a calcium channel blocker, due to whatever's going on, it's a consideration because it does not affect heart rate or blood pressure. Once again, there's the ACS. We talked about dual antiplatelet. Usually it's the P2Y12 inhibitors with aspirin, and that's for a year after an ACS event. Heparin, which we know is an anticoagulant. Enoxaparin, same, just low molecular weight, heparin. Then anticoagulants could include the GP2B3A inhibitors as a high risk for PCI. Actually, that should be an antiplatelet for the GP2B3A, but that's spelled out in your heme. There's an add-on to that sentence, but it almost looks like it's saying that GP2B3As are anticoagulants or antiplatelets for PCI. And you'll see that on the MEMORY JOG for heme. STEMI's reperfusion now. And we talked about the timelines for fibrinolytics and when you need to be in the cath lab. And then for long term, I had my event and I'm being released. Beta blockers for 3 years. And ACE or ARB for the hypertension, or remember we said ACE or ARB if you see the chronic comorbidities, i.e. chronic kidney disease, diabetes, those two leading to albuminuria, i.e. proteinuria, or albuminuria or proteinuria, then you're going to make sure that you're getting an ACE or ARB on board, just like we mentioned in the hypertension lecture. And then the statins, we haven't gone over them. Just know you're monitoring cholesterol or you're treating high cholesterol. Okay, that is that one, and we'll take just a few minutes to hit him, and we're all set. That's the MEMORY JOG from Angela. Brought up the wrong one there. I brought up the actual lecture. All right. So, first bullet there, hemostasis involves platelet adhesion, activation, and aggregation. We talked about how the platelets form clots. Unfractionated heparin, low molecular weight heparin, and the fondaparinix prevent clot propagation via AT3. So you need to know which are heparin, unfractionated, or the low molecular weights. You know which medication is which one. The direct thrombin inhibitors, they're there for you. The most common is the dabigatran, and that is obviously directly inhibiting thrombin, so that's factor 2A. The DOACs are those direct oral anticoagulants. I mean, orals benefits, right, is that they inhibit factor XA, so they don't really require any monitoring. It's an oral pill used as an anticoagulant. You can do XA monitoring, but it's not required. Versus having to do, I think the next slide we're going to talk about the INR, the APTT, and the different lab values we have to monitor for our anticoagulants to make sure that we're not having too much of a good thing on board when it comes to anticoagulation. And it says it there at the end of the sentence, no routine monitoring. Warfarin INR, remember it said winner, WINR. And know that it has a lot of drug interactions, it has a lot of food interactions. In the next slide, specifically, you'll need to know that it inhibits which factors and what are they depending on. Vitamin K, right? Then how do you reverse it? You give them vitamin K. If too much warfarin's on board and they're bleeding, start to have bleeding disorder. Matter of fact, next bullet, reversal agents, know them all. Warfarin, vitamin K. Protamine, heparin. And then the crazy idacruzumab for the dabigatran, which is that direct oral anticoagulant. The fibrinolytics that were clot busters, we talked about in angina in this lecture. There's your normal players, the alteplase. They all, well, both listed there in place, right? They dissolve clots. We talked about the indications, right? Stroke in a certain amount of time. There were 2 or 3 different indications there, and this one on your check on learning, it gives a good breakdown on the check on learning at the end of this memory jog about indications versus non-indication for a fibrinolytic clot buster. Antiplatelets, we talked about it, aspirin, and then that P2Y12, normally clopidogrel. We introduced dipritamol and cilostazol here as well. And remember the cilostazol was that PTE3 inhibitor, increases intracellular count in platelets and vascular smooth muscle. So it vasodilates and inhibits platelet aggregation. But remember, we use it mostly for intermittent claudication, i.e. you start to get that pain in your legs when you walk a certain amount of time, but completely contraindicated in what? Heart failure. Heart failure. So you do not want to use the cilostazol. Know what it does and know what it's contraindicated in. PDE3 inhibitor. On the dipritamol, that's a combination. That's Abranox, usually with aspirin. Just know you can't use it by its lonesome. It's very weak as an antiplatelet until you combine it with the aspirin. And cilostazol or heart failure, never use it. Reversal agents, we're warfarin INR monitoring. We talked about the drug interactions. Reversal agents, the vitamin K for warfarin, protamine. You'll often see the vitamin K is also for reversal going to be given with what's called PCC, prothrombin complex concentrate. In our slide deck, we have a couple of different indications. It says reversal of vitamin K or vitamin K with PCC. Know that vitamin K absolutely is the reversal, but you can also, some literature sources say to combine it with the PCC. But vitamin K is your main antidote for bleeding disorders if your INR is getting too high from the warfarin. But it can be combined with the PCC, the prothrombin complex concentrate. Basically, what does it do? It immediately replaces all of the clotting factors that are vitamin K inhibited, i.e. that warfarin works on. Iron deficiency, oral or IV, and what's going to be your side effects?
Dark stools.
Black stools and constipation. Okay. Vitamin B12 and folate, which one gives you neurological symptoms if you have deficiency? B12. Yep. TXA, we talked about it. It's used to control bleeding. That's about what you need to know about it. It inhibits fibrinolytics, it inhibits fibrinolysis. So it prevents the clots from being broken down. And then I talked to you very, very briefly about the ESA making new red blood cells, making the precursors, stimulating the precursors to be able to turn into red blood cells. Know the GP2B3A inhibitor. Know what it is and what it does and when we use it, right? Normally we said that's going to be your antiplatelet option in what? PCI, right? If you go to the cath lab, you're thinking that versus the clopidogrel. Anticoagulation, heparin, rapid onset, inpatient normally. And then you have your low molecular weights, pregnancy, enoxaparin preferred. Preferred low molecular weight heparin. Fondaparinux, alternate anticoagulation for VTE, so venous thromboembolism. Warfarin, long-term therapy, you take it not in the hospital, right, as outpatient, or hypercoagulable states. Specifically, it's the only one that we can recommend if you have a valve replacement. Warfarin is valve replacement. And then Apaxaban and rivaroxaban, DOACs, right? Inhibit XA, factor XA. Those are the DOACs, and you don't have to monitor the any INR or APTT with a DOAC. So they're preferred, right? AFib, obviously, valve replacement, warfarin. Antiplatelet therapy, we talked about aspirins for acute coronary syndromes. That's the drug of choice. Stroke prevention, drug of choice. With the dual, if you've had a STEMI, we're going to add in usually that P2Y12 clopidogrel. Know that it's not just clopidogrel. Go back and look at that slide. Clopidogrel is like the fan favorite, but there's a couple others that are used in the hospital or in the cath lab. Make sure you know them. And there's an important difference between the three. Two, clopidogrel being one, is an irreversible antiplatelet, much like aspirin. Right? Remember, we talked about aspirin, irreversible binds the COX line, and it inhibits that platelet from the COX pathway until the platelet dies, until we can make new platelets. Same thing with the clopidogrel. It's irreversible, but there is a reversible medication in that class. I'd know it, be able to pick out what it is and what makes it different from the clopidogrel. Thrombolytic therapy, we talked about it, when you can do it, when you can't. If acute ischemic stroke and STEMIs, unless it's a contraindication, which we gave you 2 slides on it. I'll look back at those, and it's also in your check on learning. And then anemia, primary therapy for iron deficiency is the ferrous sulfate, oral. We talked about the side effects. Vitamin B12, that's your B12 deficiency. You're going to get it with IM injections, how you're going to get it back in the system, and this is the one that you're worried about replacing soon, so you don't get neurological disorders. And then the folic acid, just an oral pill. We talked about alcoholics and nutritional deficiencies and some other specific scenarios. But just know, as far as anemia goes, it's another megablastic, unlike iron, which is microcytic. It's macrocytic, megablastic, big cells. B12 and folate look alike, but when you get those neurological symptoms, that's when you jump on the B12 versus folate or folic acid deficiency. Reversal agents, I talked about it, you need to know them. The vitamin K, phytonadione, often combined with PCC for warfarin reversal when your INR gets too high and you're bleeding. And then the protamine sulfate, that's heparin. And then the itacruzumab is a dabigatran, which is our direct thrombin inhibitor. Not to be confused with the direct oral anticoagulant, which acts on factors XA, versus the dabigatran, which is our only oral direct thrombin inhibitor. And that's its reversal. And that, ladies and gentlemen, is all I have for you for till Monday. So hopefully this guide's what you need to look at. It's a lot. I got it. Hopefully I broke it down into how you should approach this. Look at the memory jogs. Know them. Those are core knowledge on the memory jogs. Branch out from there. There's the disclaimers, right? I'm not saying only study the memory jogs. You will set yourself up to not do really well. But study the memory jogs and then branch out from there. If there's something you don't understand, dig into it. They're not representative of everything you're going to see on the test, but a combination of the check-on learnings and the memory jogs should guide your study. Like if you're reading those memory jog check on learning questions and you go, I have no idea why this couldn't be correct. That's when you go back and you look and see why. Because I gave you a little blurb of why it's not right. Those are clues into what you need to be looking at as far as in that lecture. Any questions in the last moment? Y'all are all going to do well. I think you're going to do well. I do. You got plenty of time. Learning by disease process, and then know your backbones, and when to add, when not to add. Mechanisms, must know the mechanisms and where they're acting, specifically on the things that act in specific locations in the nephron, what they do, and what either they increase or decrease certain electrolytes. So I have faith that we're all going to be nice and happy next Monday, and everybody's going to pass, and we're going to get good. So good luck with the studies. I know you got another test coming up before this one, so good luck on those two. And I'll hang around for 5 minutes if anybody has any questions. So listen, somebody's waiting to come on the podium. Somebody has